Good evening, everyone. I am Dr. Satyabrata, MDDM clinical pharmacologist, and today I am going to discuss on mood stabilizing agents and CNS stimulants. Then, first of all, what is mood disorders? Mood disorders can be unipolar, that is, might be depression, or bipolar, that is, alternating mania and depression, manic depression. This picture shows normal and elevated mood, that is mania, and depressed mood, that is depression. So bipolar affective disorder, manic or manic depressive disorder, a severe type of mental disorder characterized by swinging moods from extremely happy to extremely sad, and it occurs episodically, potentially lifelong, disabling, difficult to diagnose but treatable. The prevalence is 1 to 3% of the adult population, most cases diagnosed in the third or fourth decade. Coming to the signs and symptoms, the normal mood and elevated mood is hypomania, moderate mania, or severe mania. Then below it is mild depression, moderate depression, and severe depression. Then mania alternating with depression. With bipolar disorder, you shift between two extreme mood poles, that is mania and depression. Mania means insomnia, restlessness, anxiety, hostility, delusions, irritability, and paranoia. And depression means loss of energy. Patient tell that he is sad, sadness, loneliness, apathy, and lack of interest in one's enjoyable activities. What is the cause of this mood imbalance? Exact cause is unknown. A number of factors contribute, like chemical imbalance in the brain, noradrenaline, 5-hydroxytryptamine, and dopamine. Genetic factors in 80% inherited, and environmental factors, stress and seasonal changes, substance abuse, sleep deprivation, and drugs, antidepressants like etc. can cause these type of changes. Then coming to imbalance of catecholamines in brain, mood cognitive function, and there will be imbalance norepinephrine, serotonin, and dopamine. Norepinephrine, alertness, required for alertness, concentration, and energy. Serotonin requires for obsessions and compulsions, memory, and pleasure, reward, motivation, drive, dopamine. Then attention, in between that appetite, sex, aggression, and anxiety, impulse, irritability. Then coming to pathophysiology, bipolar disorder, depression, mixed states, mania. Depression, increase in acetylcholine. Mixed states, catecholinergic oblique cholinergic imbalance. In mania, there is increase in dopamine. So this is the picture showing neurotransmitter dysregulation resulting in different mood states in bipolar disorder. Then coming to treatment strategy, drugs that reduce activity of catecholamines, dopamine or norepinephrine, relieve mania, and acetylcholine or glutamate may also be involved. Coming to classification of mood stabilizing drugs, one is lithium carbonate, other is benzodiazepines, and anti-epileptics like valproic acid, carbamazepine, gabapentin, lamotrigine, topiramate can also be used. Atypical antipsychotics like olanzapine, risperidone, quetiapine, clozapine can also be used as mood stabilizing drugs. And these are used for prophylaxis in bipolar disorder. Therapeutic effects more predominant either for prevention of depression or mania, mono or in combination therapy with lithium in acute mania. Coming to lithium carbonate, it is a monovalent cation like sodium and the primary drug for mania and major depressive illness, and used for treatment of acute manic phase and as a maintenance agent for prophylaxis, but a drug of low therapeutic index. Several anticonvulsants and antipsychotics have emerged as alternatives to lithium with comparable efficacy. This is the mechanism of lithium, action of lithium, that inhibits the IP1 formation from IP2 and also inositol formation from IP1. And this is the mechanism showing effect of lithium on the IP3 inositol triphosphate and diacylglycerol second messenger system. The schematic diagram shows the synaptic membrane of a neuron, PIP2 phosphatidyl inositol 4,5 bisphosphate, PLC phospholipase C, GI coupling protein, effects activation of protein kinase C, mobilization of substrates may cause depletion of the second messenger source PIP2 and therefore reduce the release of IP3 and DAG. Lithium may also act by other mechanisms. Coming to other mechanisms of lithium, it stabilizes the neuronal activities in the brain. It mimics the role of sodium in excitable tissues, able to permeate voltage-gated sodium channels that cause action potential. It readjusts balances between excitatory and inhibitory neurotransmitters and decreases glutamate activity. Coming to pharmacological actions on CNS central nervous system affect ionic fluxes across brain cells or modify the property of cellular membrane, decreases the presynaptic release of noradrenaline and dopamine in the brain, correct any imbalance in the turnover of brain monoamines. Action of kidney inhibits the action of ADH on distal tubules in the kidney and causes diabetes insipidus like state. Coming to pharmacological actions on thyroid inhibits release of thyroid hormones resulting in feedback stimulation of thyroid through pituitary. Majority patients remain in a state of compensated euthyroidism, but few get decompensated and become clinically hypothyroid. Action on blood. What is the action on blood? An insulin-like action on glucose metabolism and leukocytosis. Coming to pharmacokinetics of lithium, absorption virtually complete within 6 to 8 hours, peak plasma levels in 30 minutes to 2 hours, distribution in total body water, slow entry into intracellular compartment, initial volume of distribution is 0.5 liter per kg, rising to 0.7 to 0.9 liter per kg, some sequestration in bone, no protein binding, metabolism known, excretion virtually entirely in urine, and lithium clearance about 20% of creatinine, plasma half-life about 20 hours, target plasma concentration 0.6 to 1.4 milliequivalent per liter, dosage 0.5 milliequivalent per kg per day in divided doses. Coming to adverse drug reactions, neurologic and psychiatric adverse effects like tremor, most common, choreoathetosis, motor hyperactivity, ataxia, dysarthria, aphasia, psychiatric disturbances at toxic concentrations like metal confusion and withdrawal. Hypothyroidism in few patients, goiter in some, reversible or non-progressive, nephrogenic diabetes insipidus and other renal adverse effects, loss of responsiveness to antidiuretic hormone ADH, polydipsia and polyuria are common. Lithium-induced diabetes insipidus is resistant to vasopressin but responds to amiloride. Long-term lithium therapy leads to chronic interstitial nephritis and minimal change glomerulopathy with nephrotic syndrome, marked azotemia or renal failure. Edema. Due to sodium retention, it can cause edema. Cardiac adverse effects. It depresses the sinus node and contraindicated in 6 sinus syndrome. T-wave flattening is often observed in ECG, electrocardiogram. And miscellaneous adverse effects are transient acneiform eruptions, folliculitis, leukocytosis. This can happen in case of lithium taking patients. Use during pregnancy. Renal clearance of lithium increases during pregnancy and reverts to lower levels immediately after delivery. Lithium is secreted in the breast milk, concentration about 1/3 to 1/2 that of serum, manifested by lethargy, cyanosis, poor suck, and hepatomegaly. Report of an increase in cardiac anomalies, especially abstinence anomaly in lithium toxicity in babies. These are some. Are you aware of warning signs of lithium toxicity? Warning signs of lithium toxicity are dehydration, lack of appetite, diarrhea, vomiting, blood vision. More severe lithium excess can lead to a marked tremor, shaking, unsteadiness, slurred speech, drowsiness, confusion. As the lithium level gets even higher, the person may experience muscle twitches, very severe drowsiness and confusion, fits, unconsciousness. Any illness leading to dehydration can increase the level of lithium in the blood. If a person on lithium starts to experience any of the above symptoms, even the mild ones, it is essential they see a doctor immediately. Then lithium toxicity causes therapeutic overdoses more common, accidental ingestion rare, and diminished serum sodium, use of diuretics, fluctuating renal function, treatment. Treatment of lithium toxicity is because lithium is a small ion, it is dialyzed readily. Both peritoneal dialysis and hemodialysis are effective. Coming to drug interactions, thiazides reduce renal clearance of lithium by about 25%. Also, NSAIDs, non-steroidal anti-inflammatory drugs, reduce lithium clearance. Typical antipsychotics may produce more severe EPS, extrapyramidal symptoms, extrapyramidal side effects when combined with lithium. Typical antipsychotics may produce more severe EPS, extrapyramidal side effects when combined with lithium. Uses of lithium. Bipolar affective disorder. Preferred treatment of bipolar disorder, especially in the manic phase. But due to high toxicity, other drugs like valproate, aripiprazole, olanzapine are used nowadays to control mania. Then low dose of lithium and benzodiazepines are used as maintenance therapy. So other applications of lithium. Recurrent endogenous depression with a cyclic pattern is controlled, lithium or imipramine. Schizoaffective disorder, resistant schizophrenia, add on to antipsychotics. In case of resistant unipolar depression, adjunct to tricycle antidepressant and SSRI, selective serotonin reuptake inhibitors. Then therapeutic drug monitoring. What is therapeutic drug monitoring? You know everything. Clinicians rely on serum lithium concentration measurements for assessing both the dose required for treatment of acute mania and for prophylactic maintenance. After 5 days of treatment, steady state plasma concentration reached. Measure lithium concentration. Adjust dose. Check again after 5 days. Once the desired concentration has been achieved, levels can be measured at increasing intervals. Maintenance treatment. The decision to use lithium as prophylactic treatment depends on many factors, the frequency and severity of previous episodes. Patients who have one or more episodes of illness per year are candidates for maintenance treatment. Although some patients can be maintained with serum levels as low as 0.6 milliequivalent per liter, the best results have been obtained with higher levels such as 0.9 milliequivalent per liter. Other drugs that can be used as mood stabilizing drugs. Carbamazepine. It was found to prolong remission in bipolar disorder. Patients who relapse on lithium therapy or those prone to rapid cycling of mood state do better on combined lithium plus carbamazepine (CBZ) treatment. The dose and effective plasma concentration range is the same as for treatment of epilepsy. Sodium valproate. A reduction in manic relapses is noted when valproate is used in bipolar disorder. First line treatment of acute mania in which high dose valproate acts faster and is an alternative to antipsychotic plus benzodiazepine. Useful in those not responding to lithium or not tolerating it. A combination of lithium and valproate may succeed in cases resistant to monotherapy with either drug. Lamotrigine, approved for bipolar disorder but is not recommended for acute mania. Useful in rapidly cycling bipolar depression. Topiramate useful as adjunctive therapy of bipolar disorder. Gabapentin also has shown some prophylactic effect in bipolar disorder. Coming to atypical antipsychotics. Olanzapine, risperidone, aripiprazole, quetiapine, with or without a benzodiazepine (BZD) are now the first-line drugs for control of acute mania. Olanzapine is also approved for maintenance therapy of bipolar disorder due to low risk of inducing extrapyramidal side effects (EPS) or agranulocytosis. and artificial antipsychotics used as adjuvant of the alternative to lithium for prophylaxis of cyclic mood swings. So then coming to novel agents, a number of novel agents are under investigation for bipolar depression, including riluzole, a neuroprotective agent that is approved for use in amyotrophic lateral sclerosis, ketamine, a non-competitive NMDA antagonist, L-methyl D-aspartate antagonist. Then coming to another chapter, that is CNS stimulants. These are drugs whose primary action is to stimulate the central nervous system globally or to improve specific brain functions. Classification: convulsants like strychnine, picrotixin, bicoculin, pentylene tetrazole (PTZ). They can cause convulsion, produce convulsion. Analeptics, doxapram. Psychostimulants: amphetamines, methylphenidate, modafinil, pimoline, cocaine, caffeine. These are psychostimulants. Convulsants. Strychnine uses of CNS stimulants, that is convulsants. Strychnine produce convulsions, banned in India. Picrotocin, potent convulsant, no use of it now. Bicoculin, competitive GABA A receptor antagonist, produce convulsions like picrotocin. It is a research tool only. Pentylene tetrazole, it is the most commonly used convulsant for testing anticonvulsant drugs in laboratory animals, but there is no clinical use. Analeptics, respiratory stimulants. These are drugs which stimulate respiration and can have resuscitative value in coma or fainting. Example: doxapram. Psychostimulant: amphetamine, methylphenidate, used in ADHD, attention deficit hyperactive disorder, in children. Modafinil. The approved indications are daytime sleepiness due to narcolepsy, apnea syndrome, and shift work sleep disorder. Other examples are pimoline, cocaine, caffeine, etc. Then coming to cognitive enhancers. These are a heterogeneous group of drugs developed for use in dementia and other cerebral disorders. Alzheimer's disease. Cholinergic activators like tacrin, rivastigmine, donepezil, galantamine. Tacrin is banned. Glutamate, NMD antagonist, memantine. Miscellaneous cerebroactive drugs like paracetamol, pyritinol, pyrithiogene, dihydroergotoxin, codergocrine, pyribedil, ginkgo biloba. So that's all for this session. Thank you very much. Like and subscribe my channel, and also you have to see lots of videos in my channels about different diseases, different drugs, and also on clinical trials. You can watch and gain some knowledge from it, and if you require more and more knowledge, then you have to go through the published articles and also the guidelines for disease management, individual disease management. So thank you very much. धन्यवाद. जय जगन्नाथ.